basically not as, it can't detect small masses in the same way as an X-ray can. Okay? So it can detect slightly larger masses than an X-ray. It's not as sensitive as an X-ray. However, let's just point out that in some situations it might be better to have a detection system that is not quite as sensitive as X-ray. So X-ray uses X-rays, in other words, it uses the energy from the X-rays to image the masses in the tissue. And it's often used for small masses, and you can use repeat X-rays over time. So in the case of breast cancer and mammography, it uses quite a low dose of X-ray, and it images the breast, and then it can be used perhaps 2 years later, and you can compare the before and the after. And if there is a mass in the breast, you will see it because it wasn't there in the previous X-ray. What's the main problem with X-rays though? Yeah, you are exposed to low levels of radiation. So, as you are biologists, you'll be aware, knowing that radiation exposure could potentially initiate a cancer, could cause DNA damage, you will realise that it is a play-off between the low levels of exposure and detection, successful detection, versus lots and lots of exposure and detection. Yeah? So this is a play-off, and in the US, where they have a different healthcare system, some people might know about this, they have a very different healthcare system to us. And there's a big push to give mammography earlier to younger women to detect cancers earlier because treatment of cancer is expensive. However, in the UK, the argument is you would be giving a greater exposure to X-ray and possibly initiating cancers by doing that. So it's a play-off. And a lot of women come to me and say, no, that I'm working on breast cancer, they're worried about breast cancer. And they say, oh, I should go for mammography. And you look at them, maybe they're 30 years old or something like that. Actually, it's not going to be beneficial because you would have to have yearly, or perhaps every couple of years, mammography. And you would then be ramping up exposure over an additional 20 years. If you're 30, it's now given at 50. So it's 20 years of X-ray exposure, isn't it? On a perhaps biannual basis. Okay. So you know this, you will be aware of this with your biology. Anyway, I can also tell you that in premenopausal women, the cells of the tissue is quite glandular, so it's very hard to pick up changes using X-ray. Okay. So what else can we use? We can use more sophisticated techniques, which are really for the whole body. Once a cancer has been diagnosed, let's assume then we've got to the point where we've had imaging, we've had histology, and we've had clinical. And everything is pointing towards this being a malignant cancer. Then the next big thing is, has the cancer gone on to spread to other parts of the body? And really important to understand that, because that is going to influence what treatment comes next. So, we have two main types of imaging which is used. There's another sort of imaging to come on, talk about later, but the two main, you get something called a CAT scan, or computer-aided tomography. And what this does, it uses a low level of X-ray, but it takes lots and lots and lots of slices. The patient has to lie very still and go into a sort of tunnel type system, and where they are actually slicing it. Now, with the CT, it's like a polo mint. Sorry to bring this down to a basic level. It's like a polo mint. You go through, and it's I don't know, about that wide. I don't know if anyone had CT scan here, or, so you know, it's like you go in, and you're passing all the way through, but you're not actually being contained within the tube. You pass through it. And it's taking slices all the way through the organ of interest, or the organs of interest, or the whole body. And basically, then the radiographers are reconstructing that in three-dimensional space. It's actually incredible. It is amazing. And you can tell from that quite a lot about the tumour. You can tell actually tell quite a lot. So I had personal experience of this in March because my mother, bless her, had smoked for 54 years and had a lung tumour which was about that big. And when I saw the X-ray, I thought to myself, oh dear, this is not great. This is absolutely horrendous. Saw the X-ray, oh dear. Anyway, they put her in the CT scanner and they sliced it all up. They did a reconstruction, and actually you could see from the CT scan that the tumour was actually encapsulated. She's a very lucky woman. It actually was encapsulated by a sort of almost like a membrane around the whole tumour. And although she got this massive tumour that took up all her left side and had moved her heart to one side, so a massive tumour, you could see from the CT reconstruction that it actually was encapsulated. And there were little areas where they were a bit iffy. Has it invaded the local area? Is it stuck to the heart? That sort of detail is what they can look at. And it's absolutely amazing. Now this is quite interesting because it does the whole body. However, the detail that you can get might be better perhaps with an MRI. And the reason for this MRI, which is using magnetic resonance, it's basically vibrating molecules within your cells, and it's giving you a special type of contrast agent which vibrates particularly well and is taken up by tumours. This magnetic resonance imaging allows a finer detail of the cancer to be detected, but it's difficult to produce entire three-dimensional constructs from that. So it's a sort of two complementary techniques. These techniques are actually requiring a lot of infrastructure. So unlike an X-ray and an ultrasound machine, which are quite relatively easy to operate, and you could imagine going into regional centres, or even possibly into GP surgeries later, this type of thing, it requires a big infrastructure. But there's a lot of movement in this space. There's a lot of work, a lot of development in this space. I haven't mentioned PET, positron emission tomography, PET. That is the most sensitive system at the moment that's available. If you imagine these techniques, these are going down in terms of most sensitive and most expensive, so they're going down in order of price. We should bear in mind then that in some parts of the world it's actually impossible to deliver this type of imaging. So it's a real thing. So when I was in the Caribbean, I was really shocked to find out that people, for example in Jamaica, if they get a cancer, quite often they either go to the French islands where they have the MRI, they actually have MRI, they have CT scan, they have everything other than PET in the French islands because they're part of France. But in Jamaica, Barbados, all the other countries, they either go to the French islands for their imaging, or they have to go to the States, they have to fly out to the States. Same in other parts of the world where basically in London we would totally take it for granted that we would have access to this type of imaging. PET scanners, they require a radioactive source that has to be produced nearby or relatively nearby. So if you're in a remote part of Africa or South Asia, they wouldn't have access to that. And actually that means that the mortality is pretty dramatic because people basically make the decision, I don't want to leave my home, I can't afford to leave my home to go and get my imaging and my treatment. So that's the reality. That's why we need new imaging and treatment regimens. Okay. We spoke about this. This is just for your reference. Okay. Biopsy. Now, as biologists, you have already had some idea about the molecular changes that happen in cancer, but you also have to have maybe an idea of some of the anatomical changes that might happen. So in order to really understand whether a cancer is occurring in a tissue, the first thing you really need to do is familiarise yourself with the normal structure of that tissue, because you're never going to be, you've got to have a baseline to compare to. So with biopsy, what they're doing is they're taking tissue specimens and they're fixing them in some sort of fixative, generally formaldehyde or glutaraldehyde, and then embedding them in some sort of matrix to make sure that they stay solid. And are you familiar with this idea of processing tissues? Some people are nodding. Okay, so just to tell you what happens if you were going to have a biopsy taken from your body, you would be it would go to a histopathology lab. It would be fixed in formaldehyde, so it would either be fixed in the outpatient department if it was taken there, put straight into some formaldehyde, or in the operating theatre, straight into some formaldehyde. Or if they wanted to do something fancy with that tissue, they might take it and freeze it, snap freeze it in some liquid nitrogen, and then cut it up. But most times they would put it in some formaldehyde. What does the formaldehyde do? Did Tony Madrick not tell you about this? Or? Good point. There's the next step is dehydration. What's the formaldehyde doing? It's fixing it, but how is it fixing it? Ooh, that's later. What is the fixation process? What are we aiming to do by fixing this tissue? It's not a trick question, it's an easy question. Yeah, we are trying to do something with the proteins. We're trying to stop the enzymes working, basically, and degrading the whole thing into a slime, mush, whatever you want to call it. What are we aiming to do when we fix tissue? We take that tissue from a patient, we put it in a pot of fixative. What is the gold standard? What are we doing?
It's kind of like
Okay, it's a preservative. And how does it work? Guys, ladies, tell me. Perfect, it's maintaining the morphology, but how? It's doing something to the proteins or enzymes? What's it doing to them? It's inhibiting them? How? Good point. It could be. It could be. It's in fact, you're all getting there. It could be binding to the active part. In fact, what it's doing is it's cross-linking them together. It's making bridges between the proteins, and it's cross-linking them. Okay, so it's making specific chemical links between the proteins. This is what it's doing, and depending how long you leave your material in the pot of fixative is going to influence how many of these wretched cross-links you get, which may be good, or it may be bad, or it may not matter at all. Yeah? So, the tissue goes and it's put in a pot, and then it goes off to the histology lab, and then a pathology, either a technician who's highly skilled, that could be one of you later in your life, or a doctor, pathologist, who's highly skilled, one of you later, chops this thing up, and they look macroscopically for where they think the abnormal areas are. And what they do actually, in fact, is they ink the tissue. They put the whole tissue in a pot of ink. It's really crude. Pot of ink, black around the edges, cut it up, and then you can see where the edges are. Really important to check if the cancer cells have all been removed or if they're still at the edges. Yeah? So, this tumour, suspected tumour, has been taken out, it's been put in some fixative, it's been inked, it's been chopped up. The next process then is a process called dehydration, so you are removing the fats and water and fats, and then you're putting it into a paraffin wax block, ultimately. You're embedding it in hot paraffin wax. I hope this is sending some alarm bells to you. A hot paraffin wax, and then the wax block is left us a lot, I should have brought some in. It's a block of tissue, and those blocks are then stored for years and years and years. Well, they're used for the diagnosis, but they can then be stored for years. So the block is then cut, and sections are cut, and you will be looking at sections next week. And what you'll be doing is you'll be looking at some sections of breast and colorectal cancer, and what you'll be doing is you'll be thinking to yourself, what is the normal architecture of a breast? Well, how would it normally look? And then you'll be looking at these specimens and you'll be telling me whether you think that they are cancerous or not, and if they are, whether you think they're aggressive or not. That's what you'll be doing. So the tissue specimens are fixed, they're cut, they're stained, they're viewed. Remember, it's only with a light microscope at the moment, so that could be something to think about. Anyway, and then yeah. So this could be done either using the conventional system, which is actually to have an operation where you are cut open. There's an incision, and the whole thing is cut and removed. Or it could be something like a true cut biopsy, which is just here, it's spelled true as in an Americanism biopsy. And what's actually happening with this is, it looks nice, but it's actually really horrible. There's opportunity, again, every step of the way there's an opportunity for improvement, yeah, for you to think about how to improve this. Basically, this is like, has anyone ever used an apple corer to remove the core from an apple? Yeah, this is basically the principle. Put it in and then pull out a bit of the tissue. And in practice, that looks a little bit like a needle, but it's not. It's more like a gun. Okay, so so basically, I should. I'll see if I can bring one in next time. I'll borrow one off my colleague, who's my collaborator. Basically, it looks a bit like a gun. It's basically got a very. Can you see the size of that hand? So it's about the size of the hand, a bit longer. The needle area, and it's basically going in, and it's taking out something a bit like, I don't know, half a centimetre or a quarter of a centimetre. It's actually quite invasive, getting this thing and pulling this whole plug of tissue out. You can imagine, but the good thing about it, well, I suppose the plus side is you're not having a whole operation. Bit of local anaesthetic, in and out, maybe that's good. You're not having to have a whole anaesthetic for a general anaesthetic. And that is then a representative sample from the patient. And that's what's then embedded. If you imagine you're a man, and this is something that has to then be investigated. So you can see then, I should use these points. So the man is feeling concerned about his prostate. Perhaps he's having some trouble going to the toilet. In other words, he needs to go to use the toilet and urinate often and frequently. But when he goes to urinate, he is unable to pass the liquid because the prostate has grown around the tube, the urethra, which is what's flowing from the bladder to allow the liquid to come out. It's quite an effeminate sort of... Oh, hang on, no, sorry, this is the... yeah, this is right. It does look rather effeminate. His legs are very shaved. Anyway, I was thinking to myself, what is this picture? But anyway, suddenly thinking, is this a man? Sorry. All right, let's get ourselves orientated then, shall we? So this chap has had his DRE, and they decided things are not looking too happy, so they want to do a sample. So what they do, they have to put this man. Actually, you don't have to fall asleep for this. You don't have to be asleep. You can be awake. It's okay. So you lie down, you have this thing is inserted into the rectum, and then you have this guide, template as it's called, to aid the accurate placement of the biopsy needle. And then what's happening is the biopsy needle, you might have an ultrasound going on as well to check out where you are position-wise, yeah? And then what's happening here with this ultrasound it's zooming up, getting an image, it's helping to guide where the sample is being taken. Now you have this, like this gun, which I showed you earlier, which is removing tissue. And so maybe you're having between 6 and 12 removed. Yeah? It's quite a lot. There's a big study going on over at UCL, Professor Emberton, who I worked with, and he got about £2 million in order to work out actually whether you need to take so many, because it's a lot of plugs that are being taken. And actually, to be very systematic, there's a clinical trial in which you can then study how the mass that's removed from perhaps the middle of the tumour is different genetically from the mass next to it, to next to it, next to it. So you can really do lots of studies. This has been going on now for, I don't know, 30 years, and no one actually knows. This isn't, we're meant to have evidence-based healthcare. We know that if you take between 6 and 12, that you can diagnose prostate cancer. What we don't know is whether you really need to take all of those, or if you sampled in the middle or you sampled on the edge, whether that would be as good. Okay? So that's what they're trying to understand. You can see that this is something that you wouldn't want your father, uncle, or brother, or yourself to be subjected to, I think. So there's a lot of opportunity. Biopsy is not straightforward. When they say biopsy, it's not straightforward. Okay, we'll be referring to the practical class. I realise I've talked to you already for an hour. Can I just remind you, though, that when we're talking about that biopsy specimen, what we're doing, we are looking at the degree that the sample is different from normal. So, in other words, the degree of differentiation is the terminology. Oh, if I could just go back to this slide. Last year, quite a few of the chaps wrote very nice dossiers about prostate cancer. But one of the things that kept reoccurring was this comment that prostate cancer is very rare in women. Can I just remind you that women don't have a prostate gland? So if you are writing a dossier about prostate cancer, it's not going to happen in women because there's no prostate gland. Now, breast cancer can happen in men because men do have breasts, yes? But women do not have. It's like saying uterine cancer is rare in men. Yeah? Please don't do it. It drives us mad. Thank you. All right. So, differentiation. A tissue that is differentiated has the architecture of that tissue. So a breast tissue has very characteristic ducts and lobules. The lung has characteristic differentiation. In cancer, you get de-differentiation. It's no longer differentiated, it's de-differentiated. So the more different it is, the more de-differentiated it is, the less normal it is, yeah? So that's one of the most important things. Okay, the second thing that we know is how much cell division is going on. It's really important. Okay? So that's what we're looking for. We're looking for numbers of mitoses. And then we're looking for this amorphous term called pleomorphism. Has anyone come across this term? Tony Madrick mentioned this term? Oh, I need to give you all a break. We'll have a break before we talk about treatment, I think. Yeah, so pleomorphism, this is the degree of morphism, difference, change, shape, pleomorphism, so very different shape, yeah? Basically shape, morph, and pleo, sort of many, yeah? So many shapes. So many shaped nuclei, different sizes and shapes. So any histopathology, you should be thinking about how normal or not do the cells look under the microscope. You can only assess that by understanding normal anatomy, yeah? So you have to do your homework. Something I'm very guilty of not doing. Then you need to know mitoses, so you need to know how many cells are dividing. You can see that by looking down the microscope, actually looking at the stained nuclei. So you can have an idea about mitoses. If you looked with an electron microscope, you could see beautifully about mitoses, yeah? If you then were wanting to get a further idea, you would look at pleomorphism, in other words, the size and shape of the nuclei. And this is really staggering. in cancer, the size and the shape really varies from one cell to the next, yeah? Because you've got different genetic changes across a tumour, haven't you? Unless it's a leukemia of one subtype. Most tumours, many different genetic changes. And as Ed spoke to you about the genetic changes, lots and lots of different genetic changes, resulting in differences in the DNA and the size of the nuclei. Okay, and then what you have is a grading scheme. So for each type of cancer, there are different grading schemes. In breast cancer, we have something called Bloom and Richardson, and it basically is a score from 1 to 3. Each of those gets between 1 and 3. It can be a total of 9, and then it's divided by 3. So anyway, but you would know for your own tumour type, which you're going to present in your dossier, of how the grading scheme should be. In colorectal cancer, there's a scheme called Duke staging. Prostate cancer, there's a scheme called Gleason score. So there are all these different schemes for grading. Now, you could actually say, why have these schemes showed up? What are these schemes? And it's just people making these things up based on the evidence that they've got, trying different schemes, seeing which ones tell us about the aggressiveness of the cancers. So this work was largely done in the 60s and 70s. Okay. Normally, the scheme tells you, obviously, about the biology. In other words, a grade 1 is usually the least aggressive, and the higher the grade is normally the more aggressive. It's not always the case, but that's the general idea. Okay. So, just comparing and contrasting then. Cytology, which is where you just get a few cells and you look under the microscope, is very relatively non-invasive, and it's quite quick, pretty quick. Histopathology, whether it's by general anaesthetic or using the true cut I showed you, is quite invasive, and it's slower because you need to fix all the things, takes longer. However, cytology is less accurate, histopathology is more accurate. And obviously histopathology, much more information about the cell biology. So it swings and roundabouts, isn't it? Is it a case of a quick diagnosis, something that could be rapidly growing, really need to get an idea very quickly in that clinic, and then bring them back for a full sort of treatment as quickly as possible, or, you know, what are we doing? In practice, nowadays, histopathology tends to be more common because cytology has this problem with accuracy. But there's a lot of work at the moment looking, for example, at primary tumour, but also seeing if patients have got circulating cancer cells in their blood, and that's using cytology. So, you know, there are different approaches here, but mostly now with the diagnostics, it's clinical imaging, and generally it's histopathology. Okay, so clinical, relatively insensitive. Imaging, very important, tells you the extent of the disease, tells you something about, possibly about infiltration, and then cytology can be quite quick, but histopathology is probably the gold standard. Okay? So these are the techniques for imaging. Now, just to remind you about diagnosis and techniques, any technique needs to be better than just flipping a coin, doesn't it? It needs to be sufficiently sensitive and sufficiently specific. Have you come across these terms? Any of you taking fundamentals? Fundamentals in something or other, biomedical science, or what's that? I can't remember what it's called, but it's fundamentals, isn't it? Yeah? You've learned about specificity and selectivity? No? Yeah? Yeah, he's saying no. They're saying yes.
I don't do it.
A lot of people are saying yes. Oh, you don't take it. Okay, that's good. So those of you who take it will be able to share with... It's not me. Specificity. Sensitivity is to do with how many false positives you're getting. In other words, how many of these are truly what you think they are, and then these are how many of these are actually cancerous and not benign. Okay, so it's to do with the positive predictive value and the negative predictive value. Overall, what we're aiming for is to understand the tumour itself and allow the stage to be determined. In other words, how far this has gone beyond the tumour mass itself. So the main international staging system, which is now an international system to allow comparisons across different nations, is around the tumour, around the local lymph nodes. So within any organ, we have the lymphatic drainage, and that goes into nodes. Do you remember this, I think, maybe, from last year? So lymph nodes, and then more distant organs, in other words, metastases. So in the breast, the lymph nodes are under the armpit, the axillary lymph nodes, and then you have lymph nodes within the breast, just by the ribs. In the colon, there are a lot of lymph nodes round and about in the colon area. All over the body, lymph nodes. So essentially, the staging system is designed to see whether the tumour has remained within the breast or whether it has gone to these nodes. Nodal spread is really important to understand because it tells us something more about the metastases. Okay? Metastases are in distant organs, and so the staging system tells us something about the size of the tumour here and the grade, whether there are lymph nodes involved, and whether there are metastases. This is really, really important for understanding tumours and the pattern of tumour presentation, people's presentation with tumours. If you start to get a lot more tumours where there's no tumour, node and metastases all at presentation, then you know something else is different is happening in your population to how it might have been 10 years before. So it tells you something about the disease. Okay, so I think we should stop, we should have a comfort break, 5-minute break, talk about tumour treatment next. Is that a good plan?